So, my name is Kaylee Hilliard, and I am the CEO of Granite Peak Healthcare Solutions. And today's clinical corner is actually put together by Dr. Carmen Taylor, who is our Chief Clinical Officer. However, she is traveling and was not able to be here for the specific one. So, you guys get to meet with me today. We'll go through the presentation, and then if there's questions at the end, then we'll have some time to go through some of that. So, with that in mind, we're going to go ahead and get started and talk about F698, the regulatory compliance for dialysis patients. Um, and I'm sorry, I'm trying to get rid of that bar down there. Okay. So what we're going to talk about today is just the regulatory framework for this tag. We're going to talk about an overview of the actual tag itself, and then what the facility accountability is around dialysis care. We're going to talk about pre and post dialysis monitoring, care coordination protocols, best practices. We'll talk about medication and dialysis support access management. And then we're also going to talk about some staff training requirements. And then we're going to round this out by some practices on how we can support patients who are, dealing with dialysis a little better. So, just make sure we're good to go here. And all right, let's get started. So, the very first thing that we're going to talk about is F698. It establishes absolute facility accountability for dialysis patient outcomes. So even though they're receiving most of the facilities that we work with, I actually do have offsite dialysis providers. There are a handful of facilities throughout the nation where dialysis is provided in-house that comes with its own set of special circumstances and heightened infection prevention protocols. So what I'm talking about today is more geared towards, our patients that go off-site for dialysis. Um, Ultimately, like we are responsible. So if a patient falls at a dialysis facility, we are still responsible for ensuring, new interventions. We are responsible for, monitoring the care, doing, 72-hour progress notes, like neuro checks, like all those things. So we're still responsible for the patient, even if they are outside at an ESRD facility. We remain fully accountable for their overall quality of care. That includes everything. So, as their skin being managed well, like if somebody, needs, an extra cushion in their chair, if they need a bagged lunch to go with them, like that's all the nursing facility's responsibility. And there are, professional standards of practice that we need to have as part of caring for patients who receive dialysis, that our nursing staff and our aides, everybody is fully aware of. And we're going to talk a little bit more about like what kind of competencies that needs to be in place, what kind of education we need to have. And ultimately, like if there's lapses in documentation or there's not follow-up on dialysis orders or, any whatever things that, we see citations on, it is the facility's responsibility. If there's concerns about the practices at the ESRD facility, those are reported separately to a separate state agency. I mean, in Colorado, you would still report to the health department that we think that they're not following infection control practices or whatever it is that, it might be that we're concerned about. There is a separate agency generally to report concerns about the ESRD facility. But ultimately, the overall patient care does fall on the long-term care facility shoulders. So, we kind of broke it down into phases when you think about comprehensive management of a dialysis patient. So, phase one, we call like the pre-transport assessment. So, pre-dialysis assessment should be in place, and the nurses should ensure that the resident's stable before they leave, that we verify that the transport is available and ready, that we've done baseline vital signs. We've looked at the vascular access, made sure that that's in place and the integrity is in place, and that we understand like what medication administration needs they have before they're going off. And what we see a lot, even on mock surveys and when buildings are getting cited for this, is just a lack of documentation across the board. Like either nurses aren't documenting in a dialysis communication form. I know that some buildings do a PCC UDA for their dialysis communication, and then the nurses will fill in whatever information comes back from the dialysis provider. I know other buildings have binders for each dialysis patient that has communication sheets where nurses are supposed to fill out the top portion of their pre-transport assessment, and then the dialysis provider would fill out the bottom half, and that's how we show ongoing care coordination. So ultimately, when we're seeing issues, it does come down to oftentimes a lack of documentation versus a lack of care. So really, when you guys are talking about training and education to your staff, really emphasizing the importance of documentation. And even like if you guys do have a notebook that goes back and forth for residents, that nurses are in the habit of documenting, in PCC or in their medical record that whatever their vital signs were that they were leaving for dialysis, and they left in good condition in a progress note. So, and then also doing a progress note for when they get back. So, yes, it's a little more documentation than I think people love to do. However, that is something that would absolutely save the facility from, getting the most commonly cited dialysis related tags. So, phase one, pre-transport assessment documentation. Phase two is really kind of taking into consideration what kind of care coordination during treatment, needs to have happened. And that might be stuff that is also evaluated and kind of taken into consideration on the pre-transport assessment. So the care coordination can include medication timing protocols, emergency contact availability, monitoring for facility notifications of any kind of complications that might arise. It also is down to like, do they need, like I said, like a sack lunch that goes with them? Do they need an extra blanket? Do they need a cushion in their chair to prevent a pressure ulcer? Those are all things that should be discussed that are part of phase two during the offsite treatment. So phase three, we look at like post-transport assessment. So after the resident is back. So post-dialysis monitoring upon return and should include vital signs, a comparison of any kind of weight changes, fluid status evaluation, how the access site looks, and also that we're monitoring for complications for 24 to 48 hours. Again, facility accountability continues 24/7 regardless of where the dialysis treatment occurs, and it does require consistent monitoring protocols. And if everybody's on the same page about what our policy, our procedure is, and our system is, it does make it so much easier to ensure the accountability around that. So when we talk about pre and post dialysis monitoring, for the pre-dialysis before transport, we need baseline vital signs that include blood pressure, pulse, temperature, respirations, ideally a body weight measurement, and facilities need to be thinking about like what scale they're using. Because you want to use the same scale every time, and you want to make sure you also have protocols in place for calibrating those scales and making sure that they're in good working order as well. Also looking at the vascular access site for integrity, determining resident stability for safe transport, and then documenting pre-dialysis medications that were held or administered, and then just a quick assessment of the resident's overall clinical condition. The post-dialysis monitoring upon return should have the comparison of the vital signs to detect hypotension or other changes, post-treatment weight to calculate fluid removal, fluid status and the hydration assessment. Again, looking at the access site for an integrity check for any bleeding or hematomas. Signs of complications, and those can include, this isn't just an all-inclusive list, but cramping, dizziness, nausea, weakness, and infection symptoms. And really, documentation is required in the clinical record, not only by F698, but also F842, which is the regulation around the resident's clinical record. Missing documentation is a regulatory deficiency. And we also want to talk briefly about just the bidirectional communication. It's not one way. It should go back and forth. And there are other things that we also need to, be communicating with the ESRD facilities to prevent further adverse events and to just ensure good continuity of care. If you read the regulation around dialysis, it does talk regularly about continuity of care. It talks about, just sharing of information, coordination of care. So some examples of things that the long-term care facility should be communicating to the dialysis facility include any kind of current medication changes, new orders, pre-dialysis vital signs and clinical status, like we talked about, any kind of nutritional concerns or dietary issues that have come up. So if people have had a lack of appetite, if their diet texture has changed, those are all things that are important to take into consideration. If their protein intake has changed as well. You're also going to want to note any psychosocial problems or behavioral issues that have come up. And this one is often missed. And I will also say that we also often miss, like if somebody's had a recent fall right before dialysis, the day before, or in between dialysis treatments. And also new onset of wounds is another one where I don't consistently see facilities doing a good job of talking about like what is going on in that patient's, day, a couple days before they head to dialysis. And then the other thing that I want to note is any recent hospitalizations or acute illnesses. That should also be communicated to the dialysis facility. From the dialysis side to long-term care, and this is where it gets a little more complicated, right? Like I feel like sometimes facilities are constantly chasing down dialysis facilities to get information. But what we should be looking from them is treatment responses and tolerance of the dialysis, post-dialysis vital signs and weights. We should be seeing laboratory results, dialysis specific orders and any kind of treatment modifications, and then making sure that we're following up on those timely as well. Any kind of equipment concerns or procedural issues should also be connected. I will say that if you read the regulation, like word for word, it does talk about like care coordination. And so, sort of like we do with hospice, it's a great idea to invite the dialysis provider to attend a portion of the care conference with the resident to kind of talk about that. I will say that the buildings that I know that have tried to do that, dialysis facilities are like, haha, no, thank you. I don't have time for that. But that does not mean that we shouldn't try to be coordinating care at that level too. We should also be seeing some coordination of care between our dietitian and the dialysis facility's dietitian as well. As far as communication protocols go, you guys should have written agreements that define communication frequency, designated contact persons, emergency notification procedures, documentation requirements, like how and who and where and what we're going to document and how that's going to happen, who's going to be responsible for it. You also need to have contracts in place for the dialysis transportation and for the dialysis provider itself. So ensuring that you have clear communication protocols is really going to be one of the primary things to avoid survey deficiencies as well. So in all of this, we want to talk about medication timing coordination to prevent dialysis washout and therapeutic failures. So as a facility and your pharmacist should be able to help with this. As well as the prescribing provider as well. So we want to identify any at-risk medications and which ones are dialyzable and subject to removal during dialysis treatment. And that does include certain antibiotics, antihypertensives, water-soluble drugs, and cardiac medication. So again, wanting to consult with our pharmacist, the dialysis center to see like when is the best time to administer those drugs or hold them. Your care plans, we really should have documentation if there's any kind of meds that are going to be held, or if there's different timing things that we're going to do, that should be kind of captured on your care plan, along with a clear rationale for it. And then other things that you want to have on there, we always recommend from Granite Peak that you put your dialysis provider on your care plan. And so the name of it, their address, their phone number on that care plan in the problem section so that it's easy to find. And then, of course, chair times, if there's any kind of special meal requests or things that need to go with them, those are all things that you could put into your care plan. You also want to coordinate with the dialysis center regarding EPO administration, phosphate binders, and vitamin supplements. Clarify which facility or clinician is responsible for each medication and include the formulary confirmation around that. Of course, monitoring and documenting any potential interactions between dialysis medications and our facility formulary per compliance protocols. But that is just a fancy way of saying make sure your pharmacist is involved and looking at all those things. Pharmacy should be looking at a monthly review of medication regimens anyway. So we also just want to make sure that they're aware and understand that that person's on dialysis and taking that into consideration for any kind of medication changes. So, when we talk about vascular access, that care requires specialized protocols for shunt and fistula management. So, ideally, we would have documentation of daily access site inspection, and staff would be inspecting the vascular access for signs of infection, such as redness, warmth, or drainage, bleeding, hematoma formation, or compromised integrity, and documenting that in their clinical record. As far as the sterile dressing changes go, we want to make sure that we're performing any or any dressing changes using sterile technique per physician order and facility protocol, following all infections control standards, and then monitoring that dressing for drainage, bleeding, or signs requiring immediate attention. And we really want to make sure that we're maintaining an aseptic field when messing at all with that sterile dressing change. As far as complication monitoring goes, staff should be assessing for complications, again, that include hemorrhage, thrombosis, infection, stenosis, and diminished thrill or bruit, and reporting any abnormal findings to the physician in the dialysis center immediately. And then I've seen situations where, starting to find some maybe potential issues, and nurses document in the clinical record that they'll continue to monitor without saying that they notified the physician. Those are really good learning opportunities for staff to make sure that they understand that this is an area and a time where we notify these people immediately. And then if you don't get in touch with them, that we are doing everything we can to make that happen, and we don't just let it go to the next shift for their responsibility. Emergency bleeding response. So if you care for dialysis patients, you need to have emergency procedures for access site bleeding, and that everybody is trained and educated on what that looks like. So then that can include applying direct pressure, calling for help, notify physician, documenting the incident, keeping emergency contact numbers readily accessible. Immediate action is required for uncontrolled bleeding. And this is something that, as long as you are caring for patients who go to dialysis, you should be doing education, training, competencies, and everybody's fully aware of what this looks like, because you don't want confusion or, not timely follow-up in this situation, because it's critical. And then, of course, critical access arm precautions, ensuring that staff don't perform blood pressure measurements, IV insertions, or venipuncture on the access arm. And we talked about posting visible signs at the bedside. That's not necessarily always ideal in terms of, home-like environment, but making sure that all staff are fully aware and that it is all over their chart, all over their care plan. Not to do those things. We want to make sure that staff and residents and families are all educated about those safety precautions. Okay, so care planning must integrate the dialysis team input and resident preferences. So it's not 272, sorry, it's actually 656, but we want to make sure we're completing the comprehensive assessment within 14 days of admission, identifying all dialysis related needs, including medical, nutritional, psychosocial, and functional status. I would encourage the facilities to make sure that this is done, sooner than 14 days. We ideally, if we know we're admitting somebody on dialysis, that we should have a lot of this information known, upon our admission assessments. Care plan should include input from the nephrologist, dialysis nurse, renal social worker, renal dietitian. Make sure we have coordination between us and the dialysis team to ensure a unified multidisciplinary approach. Again, I will say that a lot of times, in my experience, dialysis facilities are like, I'll do your little form that you're sending back and forth, but it's going to be hard for me to actually get onto a, formal meeting. That being said, still try to do it. Nutritional and fluid restrictions. In the care plan, it should address specific dietary requirements, including protein, potassium, phosphorus, sodium, and fluid restrictions based on the dialysis schedule, and making sure that we have monitoring protocols in place. We also need to have transportation and arrangements to dialysis center, and who are the responsible parties for that. And then what do we do as a facility if there's mistreatments or transportation failures or complications? We should have plans in place for how we address that. I would also say that you need to have a plan in place for residents who refuse dialysis, because that in itself is a whole other, conversation that is important to kind of know what we're going to do if somebody refuses today, but maybe they'll go the next day. So who's responsible for then coordinating, with the dialysis center, and how do we make that happen? If it's ongoing refusals, they're just tired of dialysis, they don't want to do that, ensuring that we get psychosocial involvement, maybe some mental health services to kind of evaluate, where that patient is at in regards to their ongoing refusals. And then if you have patients that are refusing, nurses need to document that they provided education and training on the risks of missing it, dialysis, and everything that they've done to try to support the patient with maybe an alternative day or whatever it is. Try to figure out the root cause as to why they are refusing. But there needs to be documentation every single time a resident refuses of the education that was provided to that patient about the risk of missing dialysis. If you don't have the ongoing education piece, then surveyors jump all over that like you are not doing what you're supposed to be doing. It's also really helpful if you can get resident and family involvement in the care planning, if they're aware of their options, their risks, the benefits, and their preferences, and, how do we really support the patient through this process. So, talking about staff training and competency validation. So, ideally, we would have education to nurses and to nursing assistants. For nurses, pre and post dialysis monitoring protocols and documentation, vascular access assessment, dressing changes, what to do with emergency complications, what to do with medication timing, how to communicate with the dialysis facility staff, emergency response procedures, equipment failure protocols, and infection control specific to immunocompromised dialysis patients. For nursing assistants, we would ideally love to see education and competencies on shunt and fistula precautions, vital sign measurement, and the significance of abnormal findings and reporting. Emergency reporting protocols, chain of command, call light access, emergency communication systems, signs of complications requiring immediate nurse notification, basic infection control procedures, and then transportation safety and resident monitoring during transfer. So ideally, this is not a one and done type of situation. If you're going to continue to care for residents who have dialysis, ideally staff get training upon hire and then at a minimum annually. If you have a dialysis related significant issue, then I would recommend that you up on the education at that time, like as needed. So, but as at a minimum, have it as something that they need to go through annually. Documentation standards. So we kind of talked about this. We talked about the pre-dialysis assessment and the post-dialysis, talking about the communication logs. This slide here just kind of talks specifically about all of those things in one slide that we've already kind of covered. And what I do want to highlight incident adverse event reports documenting all complications, mistreatments, transportation issues, access site problems, medication errors, adverse events related to dialysis, including what actions were taken and notifications made to clinicians or family is an important piece of that. And then let's talk about psychosocial support strategies to enhance quality of life for dialysis patients. So, cognitive behavioral therapy has been proven effective in reducing depressive symptoms and improving quality of life for dialysis patients. Now, this is not necessarily something that your social worker at the facility would do. CBT is a therapeutic approach that would be under the care of like a licensed therapist, mental health professional. So having a patient or offering that as an option to a patient could be very, very beneficial, especially in the early days of dialysis for, newer patients who are newly on it. It can really help help them manage just the signs and symptoms of depression, anxiety, all the things that come along with a major life change that dialysis is for patients. The other thing that we can do is if you care for a large number of dialysis patients, or you have nearby facilities that also have dialysis patients, or savvy with online stuff, is just facilitating peer support and group programs for patients. It might not be a terrible idea to do like a dialysis group or offer that for patients that are receiving dialysis, like a group activity that they can do together to kind of talk through some of the things and how they cope with this change in their life. The other thing was to consider establishing a patient buddy system, facilitating group discussions, or like I said, online support communities. So research shows that peer support significantly improves emotional well-being and treatment adherence for residents who are on dialysis. One of my favorite things to talk about is providing relaxation and stress reduction techniques. So these are things that you can teach them so that they can use them at the dialysis facility, or, if they're having anxiety about upcoming dialysis. But things like guided imagery, deep breathing exercises, progressive muscle relaxation, meditation, or yoga, all of those things are so readily available online. There's scripts, there's YouTube videos, all things that are available to patients and for us to help provide those for patients. We can also provide them with audio recordings, apps, or printed materials to support those practices. Relaxation techniques reduce depression, anxiety, and dialysis populations. Social support needs is also an important one to discuss. So, like for those lacking strong networks, facilitating connections with community resources, faith communities, or volunteer visiting programs can really help support a patient who's dealing with that, and then help them like feel a little less socially isolated as well. Um, Ensuring regular mental health screening and interventions, which social services generally should be doing with our PHQ 2 to 9. We should already have, that's a tool that's been tested to identify depression in patients. So I also think that it's great if we can just directly ask patients, like, hey, how's it going with dialysis? Are you having any concerns? How are you feeling about it? Like, those are all questions that social services can absolutely ask when they do their quarterly assessments. And kind of when you're doing your quarterly care conferences, touch base on that as well, because that can help determine if somebody needs additional mental health support. Of course, activities and purpose, helping if somebody really loves to do specific activities, but maybe it's complicated because of the timing for dialysis, or, and they're gone on their favorite day of bingo or whatever activity it is, you know, checking in with those patients to see if they're missing anything on the calendar that they really wanted to do. And then how do we kind of adjust or help support them to be able to adapt those activities to fit their treatment schedules. Really like just doing a better job of checking in with patients around that too. So again, if we have really good psychosocial interventions, it can really, really reduce depression and anxiety, improve quality of life, and just really help that person as they go through dialysis care. So for staff, when working with residents that are going through dialysis, like giving practice active listening is really important. Listening without interrupting, maintaining eye contact, really acknowledging and validating their emotions. Providing any kind of comfort measures that we can, where possible. Send them with a good blanket that they love, or their favorite jacket if they feel like they're getting cold, or, send them with the disposable cup of coffee that they love to have in the morning. Whatever it is, like small things matter, and they end up building up, and that really shows compassion for people who are having to go and spend a significant amount of time, at this facility 3 times a week. Of course, using compassionate communication, respecting their time and dignity. So, where possible, that we can make sure that transportation arrives on time, that we're coordinating to the best of our ability, making sure that people don't miss those appointments is important as well. Where we can, encourage family involvement is also very helpful. And I think providing education to family about what this looks like for them and how they can help, or if they want to go and, do their visit with their loved one at the dialysis center, if that feels, like that the resident wants that. Also recognizing that maybe their loved one might be tired after dialysis, and maybe scheduling their visits not at that time is also helpful. So just really having an environment where, we're all on the same team about the support for that patient. And I think it's also helpful to understand the physical and emotional burden of the 4-hour dialysis session. So, I mean, prolonged immobility. Patients are supposed to be sitting in the chairs for approximately 4 hours, 3 times a week. That prolonged immobility can cause physical stress, including back pain, muscle stiffness, joint discomfort, and pressure ulcers. Patients also often describe feeling trapped or confined during treatment, which can really like amplify any feelings that they're already having, depression or anxiety around it. Common physical complaints during dialysis include muscle cramps, and that does occur anywhere from 35 to 86% of the sessions. Headaches, nausea, dizziness, and extreme fatigue are also known common physical complaints. Many patients experience cold sensations as blood circulates outside the body. They might have some access site discomfort from needle insertion and the weight of the tubing. And again, post-treatment exhaustion can last for hours, affecting the patient's ability to engage in normal activities for the remainder of the day. Many patients do experience anticipatory anxiety before treatments and feel emotionally drained afterwards. And the repetitive nature of that can also lead to feelings of monotony, depression, and loss of independence. So, that is also something that staff need to be aware of. It's helpful for staff to acknowledge patient resilience because it does take a lot of courage to maintain a treatment schedule, to show up 3 times a week, to sit there for 4 hours. And I think, validating their struggle is very, very helpful. So acknowledging that they're showing up for each session requires some physical and emotional effort, like simple statements like, I know this is difficult, you're doing a great job. Glad you're making it to your dialysis, can really like help just validate that you see them and the strain that it can take. So, okay, so I covered a lot of information in a very short period of time. I'm going to open it up for questions. Anybody have questions? I'm going to look at the chat. Um, all right, nothing in the chat. Okay, anybody got anything? If not, I hope you have a wonderful rest of your day. And if you have any questions, of course, please reach out.
Send a message. Thank you.
Take good care. Bye bye.